Acute upper and lower gastrointestinal bleeding, a common indication for hospital admission, represents a high clinical and economic burden. In order to facilitate risk stratification and clinical triage, various prediction scores have been developed using different outcome measurements. As gastrointestinal bleeding occurs mostly in an emergency setting in which immediate triage is needed, a prediction score may assist clinical experience and intuition of physicians. Two commonly used prediction rules are the Rock-All score and the Blatchford score. With increasing knowledge about the cause of intestinal bleeding and the use of newer drugs like NSAID and antiplatelet therapy, new prediction scores have been developed in recent years. The predictive power of such scores is not the only indicator of whether the score should be used. Methodological quality is also important. In the paper entitled Prediction Scores in Gastrointestinal Bleeding, a systematic review and quantitative appraisal published in the most recent issue of Endoscopy, de Groot et al. Examined the performance of all available prediction scores and assessed the quality of these scores with regard to the outcome of gastrointestinal bleeding. This is what they have to say. Background and study aims. Several algorithms predicting outcomes in acute gastrointestinal bleeding have been developed over the past 3 decades. These algorithms differ substantially, and therefore the aim of the current study was to conduct a systematic review to compare their predictive performance and methodological quality in gastrointestinal bleeding. Methods. A PubMed literature search was performed up to 1st of July 2011. All studies reporting prediction scores in gastrointestinal bleeding were included. Studies were analyzed for predictive performance, and a quality appraisal of these rules was performed, for which a score range of 0, that is lowest, to 29, highest, was used. Results. A total of 372 studies were identified, of which 16 were eligible for inclusion. The studies evaluated different outcomes. Mortality, 5 studies, rebleeding 2, intervention required 2, or a combination 7. The predictive performance of the identified prediction scores varied between an area under the curve of 0.71 to 0.92, if given. The mean overall quality rating was 17, SD 4, range 9 to 25. Major methodological shortcomings were the absence of validation and absence of impact analysis. 8 of 16 scores, 50%, were determined easy to use, and 5 scores, 31%, reported some type of action based on the results. Conclusion. Substantial heterogeneity in outcomes and results was seen in the 16 identified prediction scores. Moreover, the methodological quality was suboptimal in most studies. However, we suggest that clinicians should use the best available scores according to performance and quality, which are the Blatchford score to assess the need for intervention, and the scores of Villanueva et al. For poor outcome, Guglielmi et al. For rebleeding, and Chiu et al. for mortality risk.